All right, welcome. It's our first Zoom conference. It's a little bit of a new experience for us. First off, I'd like to thank everybody for joining us tonight for this webinar. I'd also like to thank the Gildenhorn Institute for Bone and Joint Health as they've made this possible for us. It's a new format for us, so bear with us. We're used to being in an auditorium with live people. Hopefully you find this helpful and everybody learns a little something tonight. We'll start off with a 20-minute talk focusing on what's new in hip and knee replacement. We'll follow that with about 20 to 30 minutes of Q&A. I plan to go through the whole talk first, but feel free to submit your questions during the talk and we'll get to them at the end and have plenty of time for Q&A, which is usually the most popular part of the talk. So we'll get started. Hopefully everyone can see my screen. So we'll start off with the elephant in the room, COVID-19. This didn't make it in my talk last year for some reason. Obviously this has affected pretty much all aspects of life at this point, including surgery. Patients have a lot of questions about surgery timing, how it relates to COVID-19. I can speak a little bit to our experience at Sibley over the last few months. Currently, we're testing all patients prior to surgery, usually 48 to 72 hours. We have the typical precautions you guys are used to at this point, masking, social distancing. COVID-19 burden right now in the community, fortunately, is much lower than it was a few months ago, and we've been operating at pretty much normal capacity in the DC region now since June. COVID-19 patients are housed in a separate part of the hospital at this point, so we've been able to transition and function normally and manage the burden of the COVID-19 patients. Family and visitors are also, it's a little bit different, so this is a good thing for the virus. We've been able to minimize the interactions in the hospital. However, this obviously has an impact for patients that come into the hospital. Currently, family and visitors are not allowed in most cases. There are a few exceptions. Bear with us and stay tuned because hopefully the restrictions will be lifted at some point, and these policies are constantly being reviewed. Testing, the precautions, the family and visitor policy fortunately has led to virtually no transmission of the virus in the hospital. And this was not something we really understood in March when this hit, but the precautions and policies that we've instituted have worked, which has been very reassuring for me and for our patients. And so I've been able to reassure patients now that we have many months under our belt that what we're doing works, which is important. It's also affected some of the aspects of physical therapy that we do with joint replacement. We're doing teletherapy in some cases, a lot of home therapy. Home exercise programs are important. However, in-person PT also remains important for recovery, and so we can make accommodations. And again, there's been no spread that I'm aware of. The biggest impact that this has had, and frankly, this would have been slide number one had it not been for the pandemic, has been the transition to outpatient surgery. This has really been the most profound change in joint replacement over the last decade, in my opinion, and it's only been accelerated by COVID-19 as patients are more wary about coming into the hospital. I recently published an article on this. It's available online. It's a good review. It gives an up-to-date status of where we stand on outpatient hip and knee replacement. This was written prior to COVID-19, but is still very relevant. There's a lot of research still going on this, and we're continuing to learn, so this will likely be updated in the future. As I mentioned, it minimizes hospital exposure, which has become more important. For selected patients, this has become very safe. Generally, the patients we're looking for are patients that are healthy, with few medical problems or very well managed medical issues. They need to have strong social support. Frankly, they need to have an interest in it and need to be motivated to be successful. The benefit of this transition has been a number of things. One is that it seems to lead to faster recoveries. Patients are doing things for themselves faster. They seem to have a higher satisfaction with their overall outcome. It's led to tremendous cost savings. And where we've come to this point is the tremendous advances we've had over the last 10 to 20 years in anesthesia techniques, blood management, pain control, as well as a number of other things we've done to streamline the procedure that has made it just a much better experience top to bottom. So now we're going to talk a little bit about more nuts and bolts joint replacement. I want to start off just beginning because you know, I'm not sure where the audience stands on a lot of these things. So I want to talk a little bit about just arthritis in general and hip and knee replacement so that we understand what we're talking about, and then we'll talk about some of the newer aspects. We'll start off with some questions. How many people in the United States undergo hip and knee replacement surgery every year? The answer is B. We do almost 1.3 million joint replacements in America every year, which is amazing and is only going to continue to increase with all the projections that are out there right now. What disease is the leading cause of disability in the United States? It's not heart disease, it's not diabetes, it's actually arthritis, which gives you a sense of the burden of disability that this disease leads to. So what is arthritis? Usually when we're talking about arthritis, we're talking about standard wear and tear osteoarthritis. This is where the cushion or the cartilage of the joint deteriorates with time. There's also rheumatoid arthritis, which is an autoimmune disease that attacks the joint surface and cartilage as well, and it affects pretty much the whole body. We actually don't see a lot of rheumatoid arthritis anymore because the medical treatments are so good. The medications have all been eliminated. In fact, most of the rheumatoid arthritis patients that I'm seeing these days to discuss joint replacement, they're actually wearing their hips out from osteoarthritis rather than rheumatoid arthritis. So treatment options generally break down into two major categories. There's non-operative treatment options, which focus on diet, exercise, physical therapy, bracing, oral medications, sometimes topical medications, as well as joint injections. When these aren't working and symptoms are bad, we start thinking about surgical options. Arthroscopic debridement really isn't done much these days for arthritis alone, except in a few instances. The efficacy isn't there really for this, but in some patients who are not candidates for joint replacement, it's an option. Osteotomy has a small role in some knee disease, and joint replacement has really been the workhorse of curing osteoarthritis for patients and rheumatoid arthritis. Obviously, I'm a surgeon. We're going to focus mainly on surgical interventions tonight. We'll start with hip replacement. Again, we're doing close to 500,000 hip replacements every year, which is pretty wild. But again, speaks to the burden of the disease as well as the efficacy of the surgery. It's tremendous in its ability to improve pain and function. So what do we do with a hip replacement? Essentially, we replace the joint surface. As you can see up there on the right, we make a cut on the femur bone, which is the lower bone there you see, and we remove the diseased portion of the femoral head or the ball. We place a stem, which is wedge-shaped, into the femur, and usually we wedge it in, and it's got a coating that the bone responds to and actually grows on to the implant within about a month. Occasionally, we cement stems in patients that are elderly or have poor bone quality, but that's not the more common way to do it. On the end of the stem, we place a ball, which this day and age is usually a ceramic ball or some type of ceramic. On the socket side, what's called the acetabulum, we remount the remaining cartilage and prepare it for the cup, which is a hemisphere shape. We wedge that in really tight. We don't typically cement that in, and occasionally we'll place screws to hold it if needed. That also has a coating on it, on the titanium, which your body will grow onto, the bone will grow onto within about a month. Inside of that, where it says liner, is typically a plastic liner, and we'll talk a little bit more about bearing surfaces in a few minutes. But this is what a standard hip replacement looks like in this day and age, and this is a good slide of the progression of normal cartilage to diseased cartilage to what we end up doing with a hip replacement. So this topic isn't new. This is bearing surface. This is the surface of the hip replacement. However, this topic is always a what's new in replacement. It's constantly changing. It's constantly being updated. Historically, hip replacement involved a metal ball or a cobalt chrome ball and a plastic socket. There were issues over time with longevity and wearing the plastic out, and sometimes even issues with the metal. And so there have been multiple bearing surfaces that have been used. As you can see in the bottom left there, that's a metal on metal replacement. They were popular about 10 or 15 years ago. They had a lot of issues and have been off the market for the most part for almost a decade. In the bottom right there, you have a ceramic ball and a ceramic liner or ceramic socket. That has tremendous wear capabilities. However, there were some issues with fracture of the ceramic, which, while it's incredibly durable, is brittle just by nature of the ceramic. And there were a few brands that actually squeaked, which led to shifting away from them in general. I'll consider them sometimes in patients that are under 30. The standard bearing now is what you see up in the upper right, which is usually some type of ceramic ball with a plastic socket. And they made changes to the plastics about 20 years ago where they modified it such that the wear characteristics of the plastic are tremendously better, more than an order of magnitude better than they were historically, such that we're really not seeing the wearing out of the hip replacements that we were seeing in the 80s, 90s, and early 2000s, which has really been probably the biggest advancement in hip replacement in the last few decades, to be honest. Another hot topic that's been around for a while is the approach to the hip, how we actually get into the hip. The traditional approaches have been usually from the back or from the side, called a posterior or lateral approach. These have generally involved cutting muscles or splitting muscles and cutting tendons. They've been associated with slower recoveries. However, they still remain the more commonly used approaches. The anterior approach has been very popular, had a lot of press over the last decade or more. It's been advertised as having a faster recovery, and there are some potential benefits with the anterior approach. Traditionally, patients have been on their side to perform either a posterior or a lateral approach, and this is what they typically look like. This makes using X-ray very difficult to accurately use intraoperatively. The anterior approach, the incision moves to the front of the leg. There are certain types of tables, which you see down there to the right, that can facilitate the approach. Not all surgeons that do the anterior approach use a table. I actually was trained on this method and find it very helpful with the exposure. One of the major benefits of anterior approach replacement is that we don't actually cut any muscles. We work through naturally occurring muscle planes, which has led to faster recoveries. The other benefit is that with the use of this table, or frankly even without the table, the surgery is able to be performed in a supine position or on your back, which certain techniques, and the particular technique I use, allows us to use X-ray during the operation. So in real time, I'm looking at the components and the parts and taking measurements, which makes positioning the components very accurate. It allows me to measure leg lengths, and it minimizes issues with positioning, which can lead to problems. Let's see if I can get the video to play. This is a quick cartoon of the hip replacement. Incisions in the front. We split the two muscles in the front, come down to the hip, and then we're able to see the capsule in the joint. There's a little bit more work involved in that, but it gives you an idea of what it ends up looking like. So to summarize the benefits of the anterior approach is, in general, it's less traumatic of a surgery. They can be done through smaller incisions, although you can do small incisions through other methods. It potentially decreases the pain. There's less tissue disruption, faster recovery in general. With my patients, because the dislocation rate seems to be so low with the anterior approach, I don't actually give patients restrictions, which historically patients have been told they can't bend or can't cross their legs, and they have to constantly think about their hip. It really doesn't apply, in my opinion, with the technique we use from the anterior approach. It likely leads to more accurate component positioning and a lower dislocation risk. All right, so we're going to move on to knee replacement. We'll start off again by just getting everybody on the same page so we understand what we do in a knee replacement. A lot of patients think that it's like a transplant, like you make cuts and you literally just drop a knee in there. But in reality, what happens with knee arthritis is you wear the surface of the joint out, the cartilage wears out. And so the way to think about a knee replacement is it's a resurfacing. As you see on the right there, the top part is the femoral component. It goes on the femur. And you make small cuts and remove just a few millimeters of bone off the surface, and then you replace that bone you remove with metal. The bottom part, which you see there called tibial component, you again make a small cut on the tibia, removing a few millimeters of bone, and you resurface it typically with a piece of metal. In between the two, you see a piece of plastic, which is really the cushion between the two pieces. And often we put a piece of plastic on the back side of the kneecap, and that's called a total knee replacement. The materials are usually a titanium or a cobalt and chrome metal with plastic. There are a lot of designs out there. All the companies have really good performing prosthesis. Most of the prostheses are what we call off the shelf, meaning they come in different sizes, and you try to fit the size that most closely matches the patient. There's also something called a custom knee replacement, which I'll speak to a little bit more in a minute. Speaking of knee replacement, just like hip replacement, it's a very successful operation. It reliably provides, excellent pain relief, improved function across the board. However, approximately 10 to 15% of patients ultimately aren't completely satisfied with their knee replacement. And this has led to continued research and innovation to try to improve on this. If you look at the patients that are unsatisfied, if you look objectively at their functional metrics and their pain scores, virtually all of them have significant improvement in their pain and function, but for some reason this isn't translating into satisfaction for them. And which begs the question of why, and it's likely multifactorial, as I have at the bottom there. But things we think about are, is it implant motion? Is it something to do with the range of motion patients achieve? Or is it the quality of the motion they achieve, which is really how they perceive it? Is it something called joint balance, where maybe they're tight in certain aspects of the joint range of motion, but they're loose in other aspects? How can we improve that? Does it have something to do with sizing? Are we not sizing the components correctly? Does it have something to do with the patient's expectations? Or surgeons not doing a good job giving patients an accurate expectation of what they are going to have with a knee replacement? In general, if you're expecting your 18-year-old knee back, you're going to be disappointed, unless your 18-year-old knee was bad. But if you're expecting a knee that allows you to walk and sit and stand and do stairs and likely some athletic activities within reason, you're going to be very happy with a knee replacement across the board. The newer technologies that are out there right now, I'm not going to speak about all of them, but the three that come to mind are the custom knee replacement, robotics, and what's called a ligament sparing design. We'll start off with the custom replacement. It's important to have the terminology down. So when I'm speaking of a custom implant, I'm speaking of a true custom implant. This is an implant that uses a CT scan in order to build with a 3D printer, they build a unique and specific implant to the patient. No two implants are alike. They generally fit perfectly. And in addition, the implants or the jigs, the tools we use to put the implants in are also customized and unique to the patient. We actually dispose of them at the end of the surgery. Then there's something called patient-specific instrumentation, which many companies offer, and sometimes they call it a custom knee, but in reality, what it is the jigs and the instrumentation is customized, but the implants are actually off-the-shelf implants. Again, the custom knee is designed for the patient. It avoids sizing compromises that we sometimes have to make, although the major companies now have a lot more sizes. So to think of it like shopping for a shoe, we have like half sizes now, so we can more accurately represent more anatomy with off-the-shelf implants, but it still doesn't perfectly match the anatomy. The custom knee allows for better bone preservation in general. It often will minimize the soft tissue dissection because some of the balancing that takes place during a knee replacement is actually done through the implant rather than through dissection. However, as with most implants right now, we don't have outcomes that suggest that one implant is significantly better than any of the others. The custom knee has been out for 5 or 6 years at this point. We're kind of heading into midterm results, so I'm interested to see how this plays out with time as we get more data. Robotics have been a hot topic in knee replacement now for going over a decade. There are many different versions of it. Most of the major companies have robotic platforms. There are kind of two different major types. There's the image required, so this is where you have a CT scan or an X-ray or an MRI, and this is entered into the robot and the computer preoperatively, and then there's some landmarks that are taken during the operation that bring the two together, and then you're able to perform the replacement from that method. There's also imageless, where some of the newer technologies don't require CT scans or even X-rays prior. They get all the information they need intraoperatively, which can be a little bit easier to perform. There's less to gather preoperatively. It's less expensive. All of the robotic platforms at this point are implanting off-the-shelf implants, which is important to understand. Essentially what happens is the robot, after you enter the information, you're able to get pretty detailed information on the motion throughout the entire range of motion, and you can adjust the implant sizes and position, rotation, tilt in order to balance the knee really accurately. And then ultimately the robot facilitates making the cuts. Again, just like the custom knee, there is some data out there, but there's nothing at this point that is definitive that says that this actually improves outcomes. And so again, TBD, we'll see where this goes. It's very interesting technology. It's here to stay. And it's certainly something we can talk about in person. There's something called a bicruciate retaining knee that's making a comeback. There have been a couple versions that have come on the market in the last few years. This is not a new idea. It's been trialed a few times over the last number of decades. Essentially, with a typical standard knee replacement, we either remove the anterior cruciate ligament alone, or remove both the anterior and posterior cruciate ligaments, and the implant is designed to substitute for it. The thought behind a bicruciate retaining replacement is that you're able to keep both the anterior and posterior cruciate ligaments, which theoretically should lead to a more natural knee motion. However, there are a lot of challenges to this, and the reason it hasn't caught on over the years is the results haven't been as good, mainly because it's been a technically challenging operation to perform. To physically put the parts in and retain these ligaments is difficult from an exposure standpoint. Robotics actually may have a role in this and make this easier to perform. Additionally, a lot of times patients who have severe arthritis don't have either competent or functional ligaments, or the ligaments are scarred such that they're not going to allow a normal motion. So the newer versions, I'm interested to see how they play out, and we're heading towards where we may get some midterm data on these soon. And that's all I have now, and so I'm happy to answer questions at this point. If anyone has questions, you can use the question and answer function in the browser to ask a question. So I have, the first question is, reasonably healthy for age 81, need both knees done both at the same time. So this is a good question that comes up a lot. So bilateral knee replacement. There are different schools of thought on this. We know that bilateral knee replacement, the way I think about it is it's a double dose of surgery. So it's something to consider. The risks are a little bit higher, again, because it's just a longer operation. There's typically more blood loss. The patients that I think about it in general, it comes to mind, and patients have to have a couple criteria. One, they need to have two problems. They need to have bilateral disease. I have patients sometimes that are like, hey, when you're in there, can you just do the other side? And that doesn't work. The second is they need to be healthy. They really need to be able to handle the higher magnitude surgery. And then frankly, in my opinion, they really need to have a reason to have both done at the same time. And this is usually my patients that are still working, that can't afford to take time off, two separate recoveries in order to do two surgeries back to back. They may lose their job. The benefit of doing a double knee replacement, it does consolidate the recovery. So it's, in the grand scheme of things, a shorter recovery, but it's a more intense recovery initially. And there are certain types of pathology where we consider, if you have a type of deformity such that if we fix one side, it's going to make the other side not function well, we'll consider it then. So 81-year-olds, usually I'm steering those patients to having their surgeries done in a staged manner, typically 3 months or more apart, to allow their body to recover from the surgery, allow their leg to recover before we hit them with a second operation. But it is something we can discuss. Next question, what are the sports limitations? If one is really healthy except for the knee, bicycling, skiing, what can we do? I'm not someone, as a surgeon, that really gives specific restrictions in general with hip or knee replacement. The point of doing the surgery is to get patients back to doing what they want to do, to live in their life. If the reason you get out of bed every day is to play, you know, whatever, to go jog, then my goal is to hopefully get you back doing that. Now, I do remind patients that these are mechanical devices, and all things being equal, I would prefer lower impact activities after an operation than high impact, but patients can function at a high level with hip or knee replacement. So bicycling is typically excellent. Skiing is typically allowed, you know, if you can stay off the double black diamonds, that'd be preferable. But there are plenty of people that are out there skiing on hip replacements and knee replacements. The things that worry me the most about hip and knee replacement are really activities that are unstable or contact activities. Sports like basketball, soccer where you might fall, skiing if you're skiing and you're not a good skier, or you're doing risky things. I worry about fracturing around the prosthesis. So just keep that in mind. How long do total knee replacements typically last? Is the next question. Well, what we're quoting these days is that over 90% in the studies are still functioning at 20 years, which is pretty amazing. And those are the ones that we were putting in 20 years ago. So we think what we're putting in today is better. There have been studies that have looked at the different failure modes of knee replacement and even hip replacement over time. And what we found is the failure mechanisms have actually changed. I published a paper on this regarding hip replacement a few years back. And what we found was that with hip replacement in the 80s and 90s and in the early 2000s, plastic wear was a very common reason for patients to have them redone. And that was virtually eliminated with that change in the type of plastic we use. And so the common reasons patients are having to have them redone these days, and again, they're not common, but the most common reasons are infection, fracture, in hips, instability if they are dislocating, and in knees if they have an unstable knee, if they have motion that isn't normal. Otherwise, they're in general pretty durable, which is again pretty amazing. I'm going to keep scrolling down here to a few more questions here. One was a general question about what's involved in a revision surgery, and revision, it varies. It can be for all kinds of different reasons. It really depends on the diagnosis. First-time knee replacements, what we call primary hip and knee replacements, are pretty predictable most of the time. Occasionally, you can get ones that have either are conversions or have some type of unique anatomy or deformity that can be challenging. Revisions can vary, and it really depends on the diagnosis. Next question is severe lymphedema in the entire leg. How would this affect a knee replacement? It's a good question. Lymphedema, depending on how severe it is, severe lymphedema, especially ones that are required treatments or have ulcerations, can greatly increase the risk of infection. So it's something we really take into consideration. It's something we would have to look at in person to see and see how significant it is, whether it involves the surgical field. It's a little bit less of an issue when we're talking about hip replacement, but as a case-by-case basis, there can be some treatments that can reduce lymphedema, although most of the time, once you have severe lymphedema, there aren't cures for it. So this would be a case-by-case discussion with the patient. Next question was a follow-up to the bilateral replacement. The question is, if not both at the same time, how much time between? There are different ways to do this. Some surgeons have actually published on doing one and then coming back a week later and doing the second replacement, and I've not been a big fan of this. Typically a week out to 2 weeks out is when the inflammatory response is at its peak from the surgery. Patients are often anemic from the prior surgery, and so I don't do it this way. I generally like to stage them around 3 months or more out. I find that allows the body to recover. So, you know, as surgeons, we got to focus not only on the leg or the field we're operating, but we have to take the entire thing into consideration, the entire patient. And so I'm looking at their anemia, their labs, how they're feeling, and all of that plays into consideration, because a second surgery really is a second hit. So 3 months out or more generally allows you to recover the leg, which gives you a good leg to stand on for your next operation. It typically allows you enough time to fully recover and feel like you're ready to undergo another operation. So one of the questions was, I had a slide earlier talking about approaches, and so if all the benefits we talked about with the anterior approach are true, why is posterior and even lateral, why do they end up making up the majority of the surgeries? Really, this is a historic thing. You know, the anterior approach is a little bit technically more demanding, in my opinion. It does require some special training. What we're seeing is that surgeons that are coming out of training now, residency and fellowship, are often choosing to do the anterior approach. I'm one of the early generation to come out of fellowship, where I was actually trained by some of the world experts on anterior approach and came out into practice and just started doing this about 10 years ago. And that's really what we're seeing. And it's a big deal to change your approach mid practice, and that's really the main reason. You can still have very good outcomes with posterior approach hip replacement, and there are still occasions that I do it. Probably once a year, maybe once every 2 years, I'll still do a primary from the back. It's usually patients that have had prior surgery and they have hardware in the back that I really can't get to from the front, and it might need to be removed. It's about the only indication at this point for me. Some of my revisions are done from the back, but that's really the main reason that people are still doing. I have a feeling you're going to see a continued push towards this as more and more surgeons are come out of training doing it. Average recovery for a healthy person. We'll start with hip replacement. Hip replacement, generally, all things being equal, is a little bit easier recovery than knee replacement. Most patients, and again, this varies a lot by age and activity, and so this is a very general statement, but for most of my patients, they're on a walker for a few days to a week or two. They transition to a cane for about a week or two after that, after hip replacement, and then they're off of assistive devices typically between 2 and 4 weeks. And they're typically feeling pretty good anywhere from 2 weeks to 6 weeks. Occasionally, I even have to slow their recovery down if they're if they're moving too quickly. Patients that work desk jobs are often thinking about going back to work between 2 and 4 weeks. More physical work is more like 6 weeks or more after that. Knee replacements are around the same. They're just a little bit, you would add a week or two to most of those. They're on a walker for a week or two. They're on a cane for a week or two. They do more therapy, and going back to work more like 4 to 6 weeks in general. But again, it's a bell curve. I got people on the front end, I got people on the back end, but that's sort of the average. The recovery will continue to take place up to a year, but the vast majority of the recovery is in that first 3 months or so. One question was, do you do hip and knee replacements on the same side at the same time? And in general, we don't do that. For one, with the technique I use for hip replacement, it would require switching tables and instruments mid-case, which would, in my opinion, add too much time to the operation. The other is that having the hip done likely would inhibit your knee recovery. It just would be too much. So generally, we like to stage those. Not to say that it's not been done in the history of orthopedics. It's not something I would recommend. One of the questions is, will your range of motion after knee replacement improve? Most studies would suggest that the range of motion you have before surgery is a good indicator of what you'll have after the operation. That being said, there are some patients that have severe restrictions even preoperatively, where their knee doesn't come close to coming straight or doesn't flex. We don't leave the operating room without patients having functional range of motion, which is generally 0 to 120 degrees or more of range of motion. Sometimes patients can't keep that, they'll scar in, but if you have a severe restriction in your range of motion, likely your range of motion is going to improve. If you have pretty functional range of motion preoperatively, although you have pain, you're probably not going to see much improvement beyond that with a knee replacement, but your pain is going to get better. One of the questions was, for knee replacement, are all the options for replacement type and for implantation approach covered by insurance? The short answer is yes. There are, I believe there is an insurance company that has been giving issues with the custom replacement, mainly approving the CT scan for it. I've not run into that, but I've heard about it from other surgeons throughout the country. There are potentially options for low-cost CT scans. I've not had to employ it, but I did set that up for that situation if patients are still interested. But it's not, an approach hasn't really factored in, whether it's anterior approach, posterior approach, however you do the knee replacement, or hip replacement is covered. One of the questions is nerve damage common with hip replacement? So the short answer is yes, but you got to dig into that a little bit. So with the anterior approach, one of the few downsides is that there is a skin nerve that branches out into 1,000 tiny branches in the field. So about 1 out of 3 patients will have some numbness on the side of their thigh. And technically that's nerve damage, but it's not a muscle nerve. It's generally very well tolerated and can even disappear and go away. I tell patients about it on the front end so they're not surprised by it. Major nerve damage, things like femoral nerve, sciatic nerve, nerve damage that leads to functional issues and can be crippling, is extremely rare, but not, it doesn't have a 0% instance. But again, that is extremely uncommon, fortunately. How soon can I go up steps? So the answer to that question is you can do it right away in general, barring a fracture or some complication during surgery. This is one of the reasons we're able to get patients home, same day in a lot of cases. We even, our particular protocol sends a therapist out to your house even prior to the operation to discuss things like stairs and toilets and your house. They do a home assessment to help you prepare so that you understand what's expected of you and that you're going to be able to do it. But yes, you can do stairs right away. Patients that come in the hospital actually practice stairs before they leave. So it's something that can be done. Patients don't love stairs the first couple days after surgery, but you can certainly do it safely. One of the questions, will the scar be ugly? Most of the patients that get hip and knee replacement with me have what people refer to as a plastic surgery closure. Not sure exactly what that means, but essentially it's usually all sutures that are dissolvable, which minimizes the scar. We also use a skin glue that's very cosmetic. Occasionally patients have, especially as you get older, the skin quality isn't as good as it used to be, and some of those I'll use nylon sutures in order to give to hold the skin closer and allow it to heal better. I don't generally use staples in my practice, which I think helps with the cosmesis of the incision. I'm not sure it was a question, but it said several friends with same/next day go home. Is that common? The answer is yes. So if you look back, and again, this goes to the slide about outpatient replacement, where we've come from, and my article discusses this. If you look back 20, 30 years ago, patients came in even preoperatively, were in the hospital for upwards of a week. They went to rehab for 2, 3, 4 weeks. It was a major ordeal. We've seen that shrink year over year, and it's extremely uncommon for patients actually to go to nursing homes or what they call rehabs, which are essentially nursing homes. Insurance has made it hard to send patients there, but frankly, in my opinion, that's irrelevant. That trend was happening even before that. Studies have been pretty clear that patients that go to a inpatient rehab or a nursing facility have actually worse outcomes than patients that go home. So we do everything we can to get patients home. We have lots of resources for this. We can send all kinds of resources into the house. It's rare. The patients that typically go to rehab now are hip fractures, which again is not a given, but they have a higher rate of it. And they're a different patient population in general. And then occasionally patients that are elderly and really have no social support, we can do that, but I discourage it in general. What are the outcome measures for successful knee replacement? Well, subjectively, it's really just a happy patient. Again, going back to that slide, it's hard to quantify patient satisfaction, but really we want patients that are happy with their knee, that they feel like they're improved, their quality of life is improved. There are objective measures, there are a lot of them actually, that are mainly used for research purposes that can more quantify function and pain. And they're not typically used in the clinical setting. So that's really the answer to that. One of the questions, if you have a hip replacement done on one side, can you receive a cortisone injection in the other side? Generally, yes. Oftentimes, I like to wait at least a couple weeks after the operation before I would consider injecting the opposite hip, as steroids sometimes can slow your healing down. So that's my thought on that. One of the questions, I actually had a patient ask this today in the office. It said if he had a bone spur for hip arthritis and the bone spur is causing the pain, do you suggest removing the spur and at a later date doing the hip replacement? In reality, bone spurs don't cause pain. I wish they had never called them spurs because it sounds like they should cause pain. They were called spurs because of their shape. I was joking with somebody that they called them bone pillows today. Patients wouldn't really be focusing on. The bone spur is really just a sign. It's a symptom of the degree of arthritis you have. Certain patients will have a hypertrophic type of arthritis where they make a lot of extra bone, and this is probably the joint trying to stabilize itself. We remove these during the operation because sometimes they can limit range of motion, but the actual spur itself doesn't cause pain. And if you remove the spur, you would feel the same after the operation. So we don't typically perform that. Moving down a little lower. How long is a typical replacement operation and how long is the recovery time? When can you return to work? A typical primary uncomplicated hip replacement is about an hour, anywhere from 45 minutes to an hour and 15 minutes. It should be pretty rapid. The longer the surgery goes, the more risk of complications. Sometimes more complicated surgeries can take longer, especially if there's hardware to remove or deformity. Revision surgeries can take all, you know, it really depends on what you're doing on a redo. The recovery time we touched on a little bit, and return to work, again, kind of general broad strokes. Patients are doing work from home after hip replacement, usually 1 or 2 weeks out. They're returning to the office for desk work anywhere between 2 and 4 weeks, sometimes longer. And more physical work is anywhere from 6 to 12 weeks if you're a construction worker or something like that. So that was the question and answer function. We'll move to the chat function and see if there's anything else. What anterior muscles do you divide in a hip replacement? There are no muscles that actually get divided. We go between muscle planes. The plane is the tensor fascia lata. We do a modification of the originally described what's called a Smith-Peterson approach. We do what's called a Hoyter modification, where we incise the tensor fascia and then work through the fascia to retract the muscle, and then medially the sartorius muscles right there. And then essentially you're down on the rectus femoralis muscle that you'll retract and expose the capsule. And then once you are down to the capsule, you incise the capsule, and then you're in the hip and are able to perform the surgery. So that's the plane that we're in. Another question, are there cost differences across knee replacement versions? There are, cost differences. Right now, most of the time, the cost differences aren't something patients are frankly aware of, because the contracts are negotiated between the vendors and either the hospital or the surgery center. The way the hip replacements right now are, hip and knee replacements are reimbursed. Typically, the center or the hospital gets paid a flat cost, and the knee replacement or hip replacement comes out of that. And so there are cost differences. They're fairly well within a range, to be honest. I have a feeling one day, and some of this is already happening with bundle payments and other payment models throughout America, eventually that cost will be part of what the patient pays or the insurer directly pays. And then those things will become more of an issue. And this just goes to honestly, it makes me, it's maddening to discuss, but the finances of healthcare is definitely not transparent at this point. But the answer is yes, there are cost differences, and the patient often doesn't see them or feel them directly. One of the questions is nickel still being used in devices, and or finally have they removed it to eliminate an allergy issue? It's a little bit more complicated than that, so we'll talk about hips. Most hip replacements now are nickel free. They're typically titanium components with ceramic versions of ceramic or ceramic balls. There are still some rare instances where we'll use a cobalt chrome ball with some extreme outliers in size. So most hip replacements now, at least in my hands, I think I'm speaking for the country, but probably not across the board. Knee replacement's a little bit different. So the metals, the reason that we use certain metals are the properties that they have. With knee replacement, the femoral component, which is what articulates or moves on the plastic, needs to be very hard, scratch resistant, and highly polished. And typically that is a cobalt chrome metal. There's also a metal called oxinium that is a ceramicized metal that one of the companies has. So most knee replacements still do have nickel involved. There are some titanium versions. They're not put in standard across the board. There also is, like I said, this oxinium version, which we use in patients that we think may have a nickel allergy, although nickel allergy is in reality quite rare. The tibial component, which doesn't actually articulate, can be titanium or cobalt chrome, depending on the manufacturer. Let me see if I had any other questions, because we have a few more minutes. Can you have a knee replacement while on long-term prednisone? The answer is yes. Ideally, you're on a lower dose. There are some other considerations as far as how prednisone at higher doses can affect anesthesia. Most patients aren't on high-dose steroids these days. We don't see it that often anymore, but there are ways to do it. And we can talk on that on a case-by-case basis. Can one pay extra for a more rugged replacement, like a sports-friendly version? That's an interesting. So there was one other type I didn't really talk about, which is a cementless knee. This is, most knee replacements have historically been used, have been put in with bone cement. That is what is the grout that puts the replacement onto the bone. There are versions now that are like hip replacements, where you literally wedge them on and the body will grow onto them. They've had historically a little bit higher early failure rates. There have been some newer versions that have come out, and that's why they haven't been standard. They're becoming more common. The idea is that if you do get reliable cementless fixation, biologic fixation, the body's not going to ungrow from the prosthesis, where the cement fixation still is a mechanical interface that can over time degrade, and you can have loosening of the components, although this is still pretty rare. Right now, we're again getting back to the cost of it. In most places in America, the cost of the actual implant is disconnected from what the patient and frankly the insurance company pays. So you're not usually having to be charged extra for that at this point. It may become an option in the future, depending on how the payment models change. There are tests. One question was about nickel allergy and tests. There are tests out there. Unfortunately, the test that we have to test for nickel allergy, skin tests, there's even a blood study, they actually haven't been correlated yet to actual implants. And so, for instance, the skin test tests one type of immune reaction that likely is not the immune reaction that would be in play with a nickel allergy involved deeper in the body. And so if someone has a positive test, we typically like to take that variable out of the equation, even though the tests right now aren't very reliable. So we'll often opt for a nickel-free option. But at this point, that it's a very difficult thing to diagnose. In fact, in most cases, patients that have replacements that are having issues, it's really a diagnosis of exclusion. After we've ruled out everything else we can definitively test for, if they have a metal prosthesis, a cobalt chrome with nickel in it, then it's something to think about. I think that's it. Let me see if there are any other questions on the chat. I think that's it. Well, I appreciate it. I hope people found this useful. Go to my website if you'd like more information. There's a lot there. I put it together myself. Again, I'm happy to answer any questions going forward if you do. Thanks for your time.